Good afternoon, everyone. Thanks for joining us today. My name is Michael Morgenstern, and I'm the head of marketing for the Expert Institute. Today's webinar is on the topic of pulmonary embolus diagnosis and management. Our presenter today is Dr. Edward Eden. He is board certified in internal medicine, pulmonary diseases, and critical care medicine. Dr. Eden has served as a claims advisor and expert witness in cases involving critical care medicine and pulmonary diseases. After the presentation, we'll set aside some time for a Q&A. You can type your questions into the question box on your control panel, and Dr. Eden will answer you verbally. Please save your questions for the end of the presentation. Thanks again for attending, and please welcome Dr. Eden.
First slide, please. Welcome, everyone. My name is Edward Eden. Before I start my lecture on pulmonary embolism, I just want to say that I have no relationships with any pharmaceutical industry manufacturers or other things that would give me a conflict of interest from what I'm about to say. Next slide, please. So the first thing to tell you about is what pulmonary embolus is, and basically I think most people understand it as a condition where the foreign material travels to lung blood cells, or lung blood vessels I should say, and lodges in the pulmonary arteries. And most of us know that 90% of pulmonary emboli do originate from the veins of the legs. Next slide, please. So I want to go over a little bit with you the anatomy of the venous system and how pulmonary embolus affects the lungs and consequently the patient. Next slide, please. So the venous system is shown here diagrammatically. Most pulmonary embolism arises from the superficial and deep veins of the legs, and they start from below the knee, which is referred to as the distal venous system, travel up above the knee slowly, and go into the major venous system, up through the iliac veins and up through the inferior vena cava to the heart, as shown by the arrow here, which is traveling up and enters the heart on the right side of the heart, and then to the pulmonary blood vessels. I will also add that occasionally pulmonary clots come from the upper extremities, or arms as we might say, and go through the same route from the arms down through the heart and into the blood vessels. Next. So here we are at the hard diagram of the heart. You notice that there's the right ventricle on your left and the left ventricle on your right, and the pulmonary clots usually come through the inferior vena cava, up through the right atrium, through the pulmonary veins, down through the right ventricle, and out to the pulmonary vessels, or so-called pulmonary artery. Now, anywhere along this route they may lodge, but most of the time, because the blood vessels in the lungs are so small, they generally lodge within the pulmonary artery system. Now, the pulmonary artery delivers oxygenated blood, or blood to be oxygenated, to the lungs. So unless there is good blood supply from the pulmonary arteries, the blood will not pick up oxygen from the lungs. Next slide. So here's a schematic diagram of a pulmonary clot, a pulmonary embolus potential, coming up through the inferior vena cava, through the right atrium, to the left ventricle, or right ventricle I should say, and then up into the pulmonary vessels, lodging in the pulmonary arteries. Next slide, please. This slide is meant to illustrate the capacity of the pulmonary vasculature to accept clots. In other words, small clots will not have much impact or very little impact on the gas exchange properties of the lung. But once a person has sufficient amount of clot going to the pulmonary vessels, then depending on how much clot, it depends on the impact, the physiologic impact that those clots are going to have on the patient. So small clots are often asymptomatic, and usually it's the larger ones that cause symptoms and problems. Next slide, please. So the cause of thromboembolic disease, which means pulmonary emboli and venous thrombosis, those normally in the legs, the veins of the legs, which are often the site of pulmonary emboli. The causes of this are a variety. The first one, vessel damage. For example, a patient involved in an accident where the legs may be injured or broken bones would cause vessel damage to the veins of the legs. Long trips on an airplane or a car would cause lack of blood flows from the veins, which have valves in them to promote venous return, blood going to the heart. And as the blood fails to flow, it tends to clot. There are certain conditions that patients have, people have, that increase the tendency to clot. These may be acquired conditions or inherited conditions. They may be tested for by blood tests. Once the clot occurs, as I've described, blockage of the pulmonary vessels occurs, stopping the normal transfer of oxygen from the lungs to the blood. And depending on the extent of this, will depend on the symptoms and signs that will be detected by the physicians and people taking care of the patient. The loss of oxygen transfer to the blood because of the clots leads to low oxygen in the blood and may be diagnostic on occasion. But more importantly, the most common cause of acute respiratory distress and cardiac distress following a pulmonary embolus is loss of cardiac output. Next slide. In order for the blood to clot, there has developed during evolution a complex system of clot promulgation. I want to point out to you that there are various factors here which we learn in medical school. The blue ones on the left are inhibited by warfarin. The orange ones in the middle, big orange box, is inhibited by an oral agent, which we'll talk about later, and the smaller orange boxes at the bottom are inhibited by additional newer anticoagulant agents. Interruption of any of this pathway will reduce the tendency to clot and also reduce or increase the tendency to bleed. So it's a double-edged sword. Next slide. Nature has developed an antagonistic system to clotting so that when you cut yourself and you develop a clot in the bleeding site, a system is activated that will eventually dissolve that clot and allow normal restoration of blood flow in the injured area. And utilizing this system is the basis of treatment for some patients with pulmonary embolus, specifically TPA, which is plasminogen activator. Next slide. Many people think that pulmonary embolism exclusively refers to clots, blood clots coming from the legs. But in fact, in several cases that I've reviewed, there are other causes of pulmonary embolism. For example, air embolism occurs often in the hospital during insertion of central lines, venous lines, and if there is insufficient care taken, air may enter the arterial system and cause strokes and heart attacks if sufficient air is released. I've recently seen a case of fat embolism, whereby fat globules and particles are released from the site of a fracture, for example, and go to the lungs, causing the same physiologic effects as blood clots. But on pathology, no blood clot is found. Rarely, cancer and other tumors can also embolize to the lungs, causing low oxygen and respiratory distress. Amniotic fluid embolism occurs following pregnancy or delivery and is the cause of sudden respiratory distress in an otherwise healthy pregnant patient during their delivery. And finally, foreign bodies can be transferred to the lung, migrate to the lung, and lodge in the pulmonary vessels. I've recently seen a case of a venous stent that was placed in the leg, traveling through the heart, lodging in the pulmonary artery. Next slide, please. Pulmonary embolism and DVT, deep venous thrombosis, is a quite common phenomenon. It's estimated that up to 1 million persons a year suffer from deep venous thrombosis. And it's been estimated that in hospitalized patients, approximately 1 in 100 suffer directly or indirectly from the effects of pulmonary embolism. That's quite a burden in healthcare, and many hospitals are focused on the prevention and mitigation of pulmonary embolism and venous thrombosis. Next slide, please. So in the medical history, an evaluation, a risk evaluation, is important for a patient coming into the hospital for acute illness or elective surgery. These predispositions should be evaluated and would lead the care managers and the carers to increase the amount of prophylaxis that's suggested for these individual patients. And I should stress that each individual patient has their own particular risk factors. So prior venous thrombosis or pulmonary embolism, particularly chronic illnesses, especially heart disease and lung disease. Cancer is a very high predisposer for pulmonary embolism and DVT. Post-operative cases, particularly orthopedic surgery is well known to increase the risk for pulmonary embolism and DVT. We all know about oral contraceptives, pregnancy. I've already mentioned cancer. Some medications, even blood thinners themselves, can sometimes predispose to pulmonary embolism. Inactivity, particularly after long journeys, on a long flight or a long car ride, can predispose to pulmonary embolism. Some hematological disorders, such as a high increase in red cells in the blood called polycythemia, or certain other disorders, rarer disorders, can increase the risk for thrombosis. And I've already mentioned inherited or acquired abnormalities of clotting, the clues of which are usually gleaned on a thorough medical history, past medical history. Next slide, please. The presentation and diagnosis of pulmonary embolism is difficult. Next slide. And the reason is because in many patients, pulmonary embolism is asymptomatic, no symptoms at all. Now, normally, of course, this is due to the fact that the emboli that are occurring are small, and I've shown you on a previous slide that the capacity of the pulmonary vasculature to accept small amounts of clot is quite high. And so small amounts of clot going to the lung may not raise any suspicion, both in the patient or in the physician, that something is wrong. However, in the majority of large pulmonary emboli that do affect the physiology of the lung and heart, shortness of breath, acute shortness of breath, is a common symptom. However, it's non-specific. Acute shortness of breath is a common symptom in medicine and may be caused by a range from heart to lung to blood to emotional causes. So acute dyspnea is not a very specific finding for pulmonary embolism. Coughing blood, on the other hand, is a little bit more of a symptom that would raise suspicion for pulmonary embolism, but also occurs commonly in pneumonia and also in acute or chronic bronchitis, inflammation of the airways, usually due to smoking. Pleurisy is a term given for patients who present with chest pain, usually on one side, made worse by breathing in deeply or coughing. Again, pleurisy may occur in pulmonary embolism, but is not specific to this diagnosis and may occur in a variety of conditions, such as viral infections or pneumonia or chest wall problems that can cause these same symptoms. A very specific and worrying symptom and sign is unilateral, that's one-sided, leg swelling with pain, but may not have pain, but normally has pain and redness, and that is a symptom that cannot be ignored. Stroke. This is unusual for pulmonary embolism. What happens here is the clot arrives in the heart and is shunted through a window between the right and left ventricle called an foramen ovale and enters into the arterial system where it goes to the brain. So we call this paradoxical embolism. It's rare, but it has been described and it is something to think about. In acute pulmonary embolism, with a large amount of clot, which affects the cardiac function, shock is a single important initial finding on physical exam, and the differential of shock, of course, is a lot, ranging from blood loss to sepsis, and it is a non-specific finding of pulmonary embolus, but if it does occur in pulmonary embolus, the prognosis is quite poor. And in the legal world, most of the cases that I see are due to a sudden, unexpected cardiac arrest or death in an otherwise healthy, usually younger person, who on autopsy is found to have major pulmonary emboli. And this, of course, comes to the attention of not only the healthcare providers, physicians and nurses, but also to the family, who want to know normally, how is it that my loved one went to the hospital for a minor procedure and then a few days later is dead. Next slide, please. So the diagnosis is made with a physical examination, which is non-specific for pulmonary embolism, but does increase the suspicion in an otherwise healthy patient. Shortness of breath, tachypnea, signs of venous thrombosis, leg swelling, and some types of lung findings, including fluid on the lung or signs of pleurisy, inflammation of the pleura. Blood gases can be helpful. Generally, a low oxygen hemoglobin saturation, unexpected in an otherwise healthy patient, or on blood gases, a specific finding called the AA gradient, which is the difference between the arterial and alveolar oxygen. EKG changes are common, particularly in large pulmonary embolism, but are non-diagnostic. Blood tests, D-dimer and troponin, are quite sensitive, but they are not specific to the diagnosis of pulmonary embolism and may be found in a variety of other conditions, including heart disease. These days, the CT angiogram is the most common test that's used for the diagnosis of pulmonary embolism, particularly in the hospital. It has a high negative predictive value. That is, that if it's negative, you can be 99% certain that the patient did not have a significant pulmonary embolism. Other diagnostic tests by implication include Doppler ultrasound, which is now done in bedside in most emergency rooms and in the hospital, and a ventilation perfusion scan, which is helpful in some cases of pulmonary embolus, particularly those that are chronic, but is more difficult to interpret and requires some preparation. Next slide. Next slide, please. One slide back, please. There have been a variety of criteria that have been used and validated to help the clinician assess risk for pulmonary embolism. These tools are not perfect, but they augment the clinical suspicion whether or not to go ahead and do a diagnostic workup in a patient presenting, for example, to the emergency room with shortness of breath. Symptoms of DVT, for example, unilateral leg swelling. An alternative diagnosis is not present, That's very important. High pulse rate, a history of long car travel or plane travel or surgery, a prior history of pulmonary embolism or venous thrombosis, and the presence of malignancy or coughing blood. So a score that's higher or equal to 6 points would increase suspicion for pulmonary embolus and lead to further diagnostic testing. These criteria has been reasonably well validated, certainly in the emergency room setting. Less well validated in the inpatient, hospitalized patient setting. Next slide, please. So the diagnosis of pulmonary embolism occurs with clinical suspicion, I will emphasize that, by using certain criteria, validated scoring systems. But even with that, only a small percentage of patients in whom the diagnosis is suspected actually turn out to have pulmonary embolus. Once the diagnosis is suspected, then appropriate diagnostic procedures should be performed at the time the patient is seen, or certainly very near the time the patient is seen. Next slide. The problem with the diagnosis of pulmonary embolus is, as I've mentioned, is that the typical patient complaining of shortness of breath has underlying heart disease, lung disease, or emotional causes for shortness of breath. And to differentiate whether the heart is causing shortness of breath, whether the lungs are causing shortness of breath, whether emotional components, or whether it's actually a pulmonary embolus, is very difficult at times. And so the diagnosis is missed. Approximately 50% of the time does a clinical suspicion rule in pulmonary embolus, approximately a coin toss. So clinical impression by physicians is important, but it fails in a number of cases. Next slide. Once the decision is made to investigate further, the most common procedure, diagnostic procedure, is the pulmonary angiogram. And here, illustrated, is a pulmonary angiogram showing a clot in the pulmonary vessel. This is on the left side. In the pulmonary angiograms and other X-rays, the left and the right are reversed. So there's a defect in the contrast material, showing this sort of half moon effect. Now, you would think that the pulmonary angiogram would be diagnostic in most cases, but in fact, there's a small number of patients who have a false positive pulmonary angiogram, or very occasionally a negative pulmonary angiogram when the patient actually does have a clot. The most common reason for a negative pulmonary angiogram is a poor study. And the most common cause for a false positive angiogram is a poor study. I will also add that pulmonary angiograms are not risk-free, and that in a certain proportion of patients, small, acute allergic reaction to iodinated contrast, or acute renal failure may occur. So, like any diagnostic procedure, there should be a good suspicion or a reasonable suspicion that pulmonary embolism exists, understanding that only 50% of the time when suspicion is high will a pulmonary embolism actually be diagnosed. Next slide. The ventilation perfusion scan is a more complex procedure. This used to be the standard of care before the CT angiogram. All these figures are showing is that it's a two-phase study, one evaluating ventilation, how much air goes into which parts of the lung, and perfusion, how much blood flow goes to each part of the lung. And if the perfusion is mismatched to the ventilation, that is, ventilation occurs but there's no blood flow, that's suspicious for a pulmonary embolism. Next slide. And the interpretation of the VQ scan depends on clinical probability, that is, a priori clinician clinical probability, which ranges from low to high. The VQ scan is very good at ruling out pulmonary embolism. So with a low or a high clinical probability, a normal VQ scan result suggests no pulmonary embolism and no testing is required. Ranging to a high at the bottom of the table, a high clinical probability with a high probability VQ scan would require treatment without further testing. Next slide, please. A lot of issue I've seen in cases is concerning the D-dimer. You should be aware that there are a variety of D-dimer tests that are available commercially. The general recommendation is to use a sensitive D-dimer test, which is the most specific and sensitive for D-dimer levels. However, D-dimer, like a VQ scan, is more powerful if it's negative than if it's positive. So that if a D-dimer is negative and the suspicion is low, then no further testing is required. But if the D-dimer is positive and the suspicion is low, diagnostic imaging may be performed depending on the clinical circumstance. A normal D-dimer, however, is not sufficient for diagnostic purposes to confirm or exclude a pulmonary embolus when the clinical suspicion is high. Next slide, please. Next slide, please. So I've already mentioned the coagulation cascade. The advantage of anticoagulation is it reduces the risk of clot extension, that is, spread of the clot, and recurrent pulmonary embolus because it inhibits clot formation. It reduces risk. It does not treat an existing clot, whether it's lodged in the pulmonary vasculature or whether it's present in the leg veins. Anticoagulation does not increase the resolution of those clots. Those clots are resolved by the natural clot busting system of the body, the fibrinolytic system. And if that was all there was to anticoagulation, then everybody would be on it without any consideration at all. But the problem with anticoagulation is, of course, increased bleeding risk. And in some cases, this increased bleeding risk could be catastrophic. Next slide. The standard treatment for pulmonary embolus and proximal DVT, that is DVT above the knee, is acute anticoagulation for a period of time, depending as an outpatient or an inpatient treatment. There is also available fibrinolysis, which is used very occasionally for clot busting in patients in whom pulmonary embolism is life-threatening. Following the acute treatment, chronic anticoagulation is generally recommended, and these days there are some modern pharmaceutical developments that have made this a little easier. And treatment also includes prevention of further complications by risk modification. Next slide. In general, the treatment is weight-based IV heparin. It has to be monitored very carefully, specifically in the first 24 hours or so. Blood tests are taken every 6 hours to monitor how thin the blood is. You don't want it too thin, otherwise the bleeding risk increases. Low molecular weight heparin is becoming more popular for treatment and can be given as an outpatient by subcutaneous injection. The patient can do that themselves. After the heparin is given for several days, it's followed by oral agents such as warfarin or the newer agents. And I've already mentioned fibrinolytic agents can be considered for life-threatening situations. And very occasionally, the patient will be, in an acute situation, the patient will require surgery. Pulmonary artery embolectomy. Next slide. There are a variety of available agents. The discussion of this is beyond this lecture, but I will mention some of the oral agents that are now available that have certain advantages over warfarin, which was the standard agent for use in chronic therapy. Warfarin, as you probably know, requires frequent blood test monitoring and has some dietary restrictions. The newer agents do not have dietary restrictions, but up until recently there's been no antidote to them. So anyone who starts to bleed on the newer agents, such as apixaban or rivaroxaban, there was no antidote available. Now we have an identified antidote to dabigatran. Next slide. Prevention. Next slide. Early mobilization. Early mobilization is very important after surgery and even after a pulmonary embolism. Early mobilization is not contraindicated. Sequential compression device, there are a variety of them. I'll show you in a moment. We've discussed low molecular weight or unfractionated heparin, which is written for and given during admission unless there's a contraindication, and occasionally an IVC filter. Next slide. Here's a schematic view of a compression device. You notice that on the far right, the pressure at the ankle is greater than the pressure at the knee to the left. Therefore, the veins are sequentially compressed, which reduces the stasis of blood within the veins. And these days, there are a variety of systems. The problem with them is that there's no standardization, and they're generally a little less effective than heparin prophylaxis, but the advantage is, of course, that there's no bleeding risk. Next slide. IVC filters, they are controversial. On the left is one of the devices available. It looks like a little umbrella or a spider web upside down, and you would think that, you put this in the inferior vena cava on the right diagram there, and it would capture all these clots that come up from the leg veins, which are the common site, trap them, and prevent them from going to the lung. Well, in fact, different of the IVC filters, different ones have different performance. There's risk of migration, and several studies have indicated there is no significant difference in certain clinical parameters whether or not you get an IVC filter. So right now, IVC filter effectiveness is controversial, meaning that a patient can still sustain a pulmonary embolus with an IVC filter inside. Next slide. I've already mentioned this, but you'd be surprised how several patients, or a proportion of patients, do not get this type of prophylaxis. It's generally indicated for hospitalized patients with acute illness and major post-operative major surgery, but still requires assessment of benefit versus risk. Next slide, please. Prophylaxis is effective to a greater or lesser degree for the prevention of DVT and risk reduction for pulmonary embolus. Remember that prevention is not 100%. However, next slide, please. The effectiveness is variable depending on the clinical condition, particularly medical versus surgical. Most studies show reduction in the risk of PE, but there's no difference in the risk of DVT or death from all causes. And some studies, under certain circumstances, show that prophylaxis increases the risk of significant bleeding. Next slide. Prognosis is determined by the underlying medical condition of the patient, their cardiopulmonary reserve, how sick they are when they get the pulmonary embolus. It depends on the extent of the clot, how much of the pulmonary vessels are involved, whether the clot is massive or submassive, whether there is a saddle embolus, and whether the patient develops cardiopulmonary arrest, which carries a high mortality. Next slide. Here is a saddle embolus shown by the arrow. I've given you a saddle just in case you're not clear what that means. And you can see here that this clot, the dark stuff, is obstructing both the right main pulmonary artery and the most of the left main pulmonary artery, preventing blood supply to the alveoli and preventing oxygen uptake for the body's metabolism. Next slide. Remember also that complications of DVT and pulmonary embolus include chronic heart and lung disease, a condition called pulmonary hypertension, which puts a strain on the heart, and post-phlebitic syndrome of the leg veins, which can cause ulcers and chronic disability. Next slide, please. Just want to go over special situations in the last few minutes. Next slide, please. So prophylaxis for orthopedic surgery, major operations, is generally started just after, but may be started before the operation, and is continued for a period after surgery, generally until rehabilitation occurs and the patient is quite mobile. Next slide. Neurosurgery is dictated by the type of operation and the risk of bleeding. Neurosurgeons often prefer mechanical devices, which I've spoken about, which can reduce but not eliminate the risk. And certain operations and procedures carry a greater risk of bleeding with bad complications. And so usually in neurosurgery, the risk is evaluated before the operation. Next slide. Pulmonary embolism during pregnancy is sometimes devastating. Again, high-risk cases are evaluated and the appropriate prophylaxis performed, and sometimes this is continued following the delivery. Next slide, please. So I just thought, as I have a legal audience here, that I would just talk a little bit about some of the departures from standard of care that I've had reason to think about in my experience. Next slide. So failure to diagnose. So I've already said that the symptoms are non-specific and transient. There may be no symptoms at all. There may be no leg swelling. There may be no recognition, either the patient or the physicians, of symptoms that may occur before the actual embolus. There may be failure to appreciate risk factors and differentiating from other causes of symptoms, such as heart disease. And sometimes it's just bad luck. Next slide. Failure to prevent. There may be a perceived but not true relative or absolute contraindication to anticoagulation. That risk factors may not be appreciated and recognized, that hospital guidelines may not be followed completely, and the patient may be responsible in some cases for poor compliance with treatment and poor follow-up for monitoring of their blood tests. Next slide. Failure to adequately treat. Hospital protocols are not followed properly. No hospital protocols in some cases. Transition from heparin to oral agents is not followed precisely. Monitoring of warfarin may be deficient, and there may be contraindications that prevent adequate treatment. Next slide. And furthermore, there are complications of therapy. Hemorrhage, I've spoken about. Clotting developed as a result of heparin, which is rare but has occurred. And IVC filter complications, including migration of the filter and clots occurring more frequently in the legs because of the stasis caused by the filter. Next slide. I just want to finish by talking about guidelines. Guidelines are imprecise. There's general agreement that treatment for PE or DVT should be continued for at least 3 months and sometimes longer for those patients at higher risk. Distal DVT, that is below the knee, may not require anticoagulation, but may be followed with venous studies, and thrombolysis, dissolving of the clots, is not recommended for pulmonary embolism without hypotension, cardiac collapse. Next. So in summary, pulmonary embolism, DVT, is common, frequently under or undiagnosed. Hospital prophylaxis is effective to a greater or lesser degree in reducing the risk, but the compliance is variable and risk-benefit ratio needs to be evaluated. The guidelines differ, are not universally accepted or adopted, and may, in cases, be based on weak scientific evidence. Next slide. Thank you very much.
Great. Thank you, Dr. Eden. That was an excellent presentation. We'd like to open it for a Q&A session now to the audience. If anybody has a question, please type it into the question pane and Dr. Eden will answer you verbally. All right, Dr. Eden, the first question. This is from Sherry Stewart. Excellent presentation. My question is, in the inpatient setting, is it worth the risk cost benefit to perform either the VQ scan or a CT angio for an inpatient with high risk before moving to a rehab facility or discharge home? Say, for example, they were in an MVA surgery immobilized for a number of days before DC, they received a prophylactic test.
As I understand the question, is it worth getting a CTA in a high-risk patient with no symptoms or signs of pulmonary embolus following some sort of inpatient procedure? There's no recommendation at all that should be the standard of care, we do not generally recommend it, and I would not recommend it unless there was a suspicion of a pulmonary embolus. Remember that CT angiography does carry a risk of dye allergy, there's radiation exposure, and in hospital patients it can be difficult to interpret the studies. So I don't recommend CT angiography under those circumstances.
Great. Next question. Early mobilization in a PA patient without a filter placed, is it not contraindicated?
So the question is it not contraindicated to mobilize a patient with a pulmonary embolism? The answer is no, it's not contraindicated. It's a common misconception that early mobilization in a patient with pulmonary embolus increases the risk of pulmonary embolus. It does not. There's no evidence that it does. There's been some isolated case reports, but in my practice is that the sooner one mobilizes the patient, the better. And the reason for that is that mobilization of the patient activates anti-clotting systems in the body and increases blood flow in the legs. So the worst thing, if the patient is clinically stable following a pulmonary embolus, I'm not saying if they've got low blood pressure or their oxygen is low, but as soon as they've recovered from their acute event, they should be mobilized as soon as possible to prevent further clots from forming.
Okay, next question. I have a client who had silicone injections during cosmetic procedure, diagnosed in ER with pneumonia. Foreign body, silicone, traveled to the lung after injection and lodged in her lung, resulting in death. Only test was EKG. No leg swelling or coughed up blood. My question is whether this met the standard of care. She had visited ER the day before with the same symptoms, shortness of breath, and she had received buttocks injections in a non-medical setting.
Yeah, I'm not going to be able to answer that question specifically regarding standard of care, but I will tell you that this is a well-known. We've had a case here at this hospital. This is a reported phenomenon. I also will tell you that liposuction as a cosmetic procedure is also associated with the development of fat emboli to the lung and respiratory distress.
Okay, next question. Thank you, great job. What are the most common symptoms leading to the diagnosis of a PE?
The most common symptom is shortness of breath, which is of new onset in a previously stable patient. Now, I've also told you as a caveat to that, that shortness of breath is a very non-specific symptom. And as a pulmonologist, I see that all the time, and I'm not working up everybody for pulmonary embolus. Nevertheless, a new onset of shortness of breath in an otherwise stable patient should raise the diagnostic possibility of pulmonary embolism, amongst other things.
Next question from Graham Bennett. Dr. Eden, where a blood clot is identified following orthopedic surgery, what significance, if any, would you place on whether the clot is above or below the knee, and would you anticoagulate?
Mr. Bennett, thank you for your question. In general, venous thrombosis below the knee carries less of a risk for pulmonary embolus than clot extending above the knee. There are a variety of courses, the options, one of them being continuing monitoring of the clot. In other words, if you do a study and then you come back a month or 2 weeks later, perhaps, and the clot has extended and increased, that could be considered a reason for anticoagulation. But some surgeons with high-risk patients will anticoagulate in a patient with a below-knee clot.
Okay, next question from Kim Steele. These are the facts. 45-year-old woman undergoes surgery to remove her thyroid. Risk factors: 45 years of age, anesthesia time greater than 30 minutes, taking tamoxifen, slightly overweight, diabetic, high blood pressure. Drugs are Lantus, Novolog, Metformin, lisinopril, oxycodone, insulin, zolpidem, not mobile due to drugs. With these risk factors, what is the standard of care regarding this, the use of anticoagulant drugs before, during, or after surgery? She died in her home of PE 11 days post-surgery.
Yeah. Well, again, I'm reluctant to give a definitive answer to that. You know, blood clots are more prevalent occurring in lower extremity surgery, such as orthopedic, in abdominal surgery, or when there's prolonged hospitalization. Generally, outpatient procedures or short operative procedures you know, need to be evaluated on a case-by-case basis. So that's all. That's all I can say or want to say about that specific case.
Next question. This is from Martin Smith. Fantastic presentation, doctor. Regarding IVC filters, in your experience, do you see failure rates occurring more often at the site of the IVC filter installation?
Yeah, that's a very interesting question. Mr. Smith, there is a failure rate for IVC filters. In certain circumstances, it's the best we have. There's a failure rate for mechanical devices, compression venous devices. Under certain circumstances, that's the best we have. So my answer is basically, if there are contraindications to more definitive therapy, IVC filter can reduce the risk, but there is a significant failure rate. And as I mentioned before, death, all-cause mortality, is not necessarily prevented by IVC filter placement. And IVC filter placement should be removable. In other words, there should be, because the complications increase if you put in a permanent fixture. If you can remove it, the complications are reduced.
Okay, that's all for our Q&A this afternoon. Thank you all for attending, and thank you very much for an excellent presentation, Dr. Eden. If any attorneys are interested in retaining Dr. Eden as an expert witness, please contact the Expert Institute and we will facilitate the engagement. Thanks again, and stay tuned for more webinars coming soon.